Sorry. Welcome everyone to Asthma Canada's Speaker Series webinars. Can people hear me? If people can, please type in a yes in the chat box, which is to the left side of the screen. Great, I'm seeing some yeses, so looks like people can hear me. So again, welcome. This is our first webinar this year, and I hope that everyone can hear me properly. My name is Manaz Rahman, and I am the Manager of Programs and Services at Asthma Canada. Thank you again for joining us today. Before we start out, I have a few quick things to share. Please note that the webinar will be recorded today and will be made available later on our website and YouTube channel. So please feel free to contact me at any time to request the URL. Also, all the attendees today are muted, but if you have any questions, please type them into the chat box, which I will be monitoring throughout the session today. There will be a question and answer period at the end of the session, and Dr. Ellis will try to get to all the questions at that time. Now, very quickly, before we begin, I would like to highlight some of the work that we do here at Asthma Canada. We are a small national organization solely dedicated to helping all Canadians affected by asthma. We are committed to improving the lives of the Canadian asthma community through education and support services, research, and advocacy. We provide education and support to patients and their families and communities, both in print and online. We offer free services like our asthma and allergy helpline, which gives all Canadians access to certified respiratory educators. We also advocate to the Canadian government on improving health outcomes for people with asthma. Our current priorities include clean air, clean energy, national pharmacare, and providing equitable access to medicines and medications and treatment options across the country. You can learn more on our website and join us by participating in our active letter writing campaign to government representatives on this issue. We support research for improved treatment options and to find a cure for asthma as well. We recently kicked off a new addition to our national research program to provide grants to emerging asthma researchers in Canada in partnership with Allergen NCE. You can find details on this on our website. Additionally, much of the work we do is with our volunteers and members across the country, people living with asthma, their families, parents, caregivers, communities, healthcare providers, educators, and others who are committed to improving asthma care in Canada. The Asthma Canada Member Alliance, or ACMA, is a free membership of Canadians who engage in the work we do and help provide input and their voice in our initiatives. If you aren't yet a member, we strongly encourage you to join us by visiting www.asthma.ca/join. Lastly, we have another great webinar coming up in celebration of World Asthma Day on May 1st on the impacts of the environment on asthma. Registrations are now open on our website, and I will provide the link to the chat box. Please be sure to register. And now I would like to introduce our distinguished speaker for today, Dr. Anne Ellis. Dr. Ellis is a professor in the Department of Medicine with a cross-appointment to the Department of Biomedical and Molecular Sciences at Queen's University. Her position is one of a clinician scientist with 70% protected time for research. She has served as the chair of the Division of Allergy and Immunology since May 2010 and is the director of the Allergy Research Unit of Kingston General Hospital. The flagship of this research program is the Environmental Exposure Unit, an internationally recognized and validated controlled allergen challenge model of allergic rhinitis. She's also involved in clinical trials of novel therapies for asthma and has studied the safety of novel immunotherapies in patients with asthma. Welcome, Dr. Ellis, and please feel free to unmute yourself at this point, and I can hand over control to you.
All right, thank you very much, Manaz. I'll just wait for everything to officially transfer over here, and thank you for all of you who have chosen to give up your lunch hour to join in today. As Manaz mentioned, there'll be Q&A at the end, but I've also included my contact information on the cover slide here, so that you can feel free to write after the webinar if we run out of time. So I'm going to go to this one. Oh, I've lost control of the slides, Manaz. Worked twice the previous times. No matter how many times you practice, sometimes there's always something.
Are you able to control it at this point?
No, still not. Oh, there it goes. Now we got it. All right. So
Okay.
as always, I always have a disclosure slide. Again, none of these associations are affiliated with today's presentation, as this is a free webinar. But again, the disclosures are there for what it's worth. Being slow. So what I'm hoping that the attendees will take away today are some insights into some apparent paradoxes in asthma management today. As you saw from the invite, there's a lot of concern about the fact that the overall rates of asthma have not really changed despite of many advances in treatment. There's a clear disconnect between patient perceptions about their level of asthma control and their scores on objective asthma control questionnaires. And finally, there's ongoing issues of overuse of short-acting beta agonists, that's what SABA stands for, despite the fact that we, as physicians, have a very enhanced understanding of the underlying pathophysiology of asthma. And so I hope to provide an overview of how some of the management options we have available currently can help to resolve some of these paradoxes. I'll try to remember that there's a bit of a delay between me hitting advance the slide and it actually going.
Dr. Ellis, sorry, I think there is an issue. Let me try and move the slides for you.
Okay, so you can, if you want to try advancing it, perfect.
Yes, please.
So again, this audience probably doesn't need to have a full definition of asthma, but I think it's helpful to know and remind ourselves that we're talking about a chronic disease that's characterized by inflammation and episodes of symptoms and exacerbation when there's times of worsening inflammation. We make this diagnosis not just from symptoms, but it's important to have an objective assessment of lung function in context with symptoms such as wheeze, cough, chest tightness, and shortness of breath. Again, we currently still categorize asthma by symptoms and severity, but not by the underlying pathophysiology, and that's something we hope to change over the ensuing decade. Next slide. I've lost my slides, Manaz, in my view, but all right, perfect. So because of this known history of asthma being an inflammatory condition, we tend to divide our medications, generally speaking, traditionally, into those that provide maintenance therapies, which controlled inflammation, and reliever therapies, which relieve bronchoconstriction. Next slide. But it's important to recognize that while there's chronic underlying inflammation in asthma, we also have times of acute inflammation. And that's when thinking about what we can do at the times of those acute symptoms should be reconsidered in the current management strategies rather than just always relying on things that help to open up airways, because if you're having extra symptoms, it means you're having extra inflammation. We know that this ongoing chronic inflammation does lead to chronic structural changes, and without controlling that inflammation, we increase the future risk of issues. Next slide. I wouldn't be an allergist if I didn't talk to you about allergic triggers of asthma. So it's important to recognize that asthma can be triggered by a number of things, not only allergens such as dust mites, mold spores, animal dander, pollens, and other irritants and pollutants, but there are other factors such as aspirin, beta blockers can sometimes worsen asthma. Some patients will have clear physical triggers such as exercise and cold air, and there are physiologic factors that are important as well. So we know stress can significantly exacerbate asthma, as can uncontrolled gastroesophageal reflux disease, having a viral or a bacterial respiratory tract infection, and uncontrolled rhinitis, whether it be allergic or non-allergic, can worsen asthma as well. Next slide. So let's talk about the prevalence of asthma in Canada. We know it's increased exponentially over the past 20 years, but currently has plateaued and stabilized. Our prevalence is still one of the highest in the world, but it seems to be stabilizing at about 8% of the general population, and at least 12% of children have asthma. Next slide. So coming to the first paradox, if we have so many effective therapies for asthma, why are the rates of asthma not declining? Next slide. Well, let's look at the risk factors for developing asthma in the first place. We know genetics is an important underlying factor, particularly if there's a maternal history of asthma or allergy. having allergy or being atopic yourself is a risk factor for developing asthma, exposure to tobacco smoke, whether first or secondhand, obesity, exposure to air pollution. Looking at all the above, only one of them is even potentially modifiable, and that's the tobacco smoke exposure. Next slide. So talking about allergy and how it's a risk factor for asthma, this is a really good study that was a very long-term follow-up of first-year college students in the United States. So these were 17 and 18-year-old individuals who were mostly male, but the author followed them forward for at least 23 years and look at the difference in the incidence rate of developing asthma if you had allergic rhinitis at baseline. Was significantly increased therefore we now know that this is a significant risk factor for going on to develop asthma. Next slide. I mentioned that air pollution is a potentially important as a cause of asthma. It's very complex, and I'm obviously not going to have time to get into all the different interactions about this, but interestingly, this study from next month's webinar presenter, Chris Carlston, looked at how there are certain gene variants that clearly, if you had those particular gene variants and had that genetic predisposition, then air pollution was actually causal for asthma in those individuals. Air pollution is a clear trigger for asthma and causing symptoms once you have it, but there is some data now gradually building that in certain susceptible individuals, air pollution can actually cause you to develop asthma in the first place. Next slide. So when we think about the therapies we have for asthma, yes, we've got a myriad of them now, and in fact, later in the webinar, you'll see the laundry list of available therapies we have in Canada. But if you look at what the mainstays of therapies are, short-acting beta agonists to relieve bronchoconstriction, inhaled corticosteroids, which help to reduce inflammation in the airways. We've got long-acting beta agonists, long-acting muscarinic antagonists. We have a stable of new biologics that are very effective in controlling symptoms of asthma, but none of these are a cure for asthma, which helps to explain why we're still faced with the paradox of, despite having all these great therapies, the prevalence of asthma is staying the same. Next slide. So let's talk about paradox number 2, which is a big issue in this field. There's a clear disconnect often between perceived control and actual control of asthma. Next slide. So first of all, how do we evaluate our symptoms of asthma? There are tools available that we can get our patients to use, such as the 30-second asthma test, which tells you within a series of 5 questions, do you cough or wheeze more than 4 days a week? Do you wake up at night? Do you stop exercising because of your asthma over the last 3 months? Do you miss work or school because of asthma? And do you use your rescue medication more than 4 times a week? So that's one way of a little bit more objectively evaluating your asthma. And this is very similar to what we'll talk about later, the ACQ, or the Asthma Control Questionnaire. Next slide. These are our Canadian guidelines for what physicians should be asking to try to determine whether or not someone's asthma is well controlled. Very similar, same sort of concept of what's in the 30-second asthma test and also what's in the ACQ. So again, we want to make sure that patients have daytime symptoms less than 4 days a week. They're not having any nighttime symptoms. They're not limiting their physical activity. Exacerbations are infrequent and when they do happen are mild, that they're not missing work or school due to their asthma symptoms, and using less than 4 doses of their short-acting beta agonists per week. I won't get into the objective tests in this discussion. Next slide. So let's take some of those nice tools that help you determine whether or not your asthma is actually well controlled. This is a very large study. That actually took place over 11 countries, a big global study that was conducted that looked at a large number of patients, as you can see, almost 3,500 patients with asthma, and looked at their scores on the ACQ, which again is very similar to the 30-second asthma test, to determine whether or not they were actually controlled based on their perception of control. When you look at those patients, to the 28% who actually had well-controlled asthma based on their ACQ scores, 96% of those people actually perceived their asthma as being relatively good. However, when you look at those who were only partly controlled, the middle group, the 21% there, 87% of those people thought they were doing quite well also, but in fact they were only partly controlled based on objective scoring. And finally, we have 51% of patients who clearly had uncontrolled asthma, and over half of them thought they were doing just fine. So it's why there's a clear issue that sometimes patients will think that their asthma is doing well when clearly they're actually uncontrolled. Next slide. And it doesn't seem to matter whether you have mild, moderate, or severe asthma. This took the same type of data and broke it down based on where you were on the GINA criteria. And we haven't had a chance to chat about GINA, but essentially it's a stepwise advancement in therapy. So patients who are GINA step 1 are patients who are managing their symptoms with just PRN short-acting beta agonist. Step 2, they've now added in a low-dose inhaled corticosteroid. Step 3 and 4, they're using combination therapies with an inhaled corticosteroid plus a long-acting beta agonist. And step 5 are patients who are using high doses of these same agents, plus or minus oral steroids, or perhaps they're actually on a biologic. And what's interesting is that asthma control was poor at all stages. So if you look at the people in the gray bars, those are people who on their ACQ scores met the criteria for uncontrolled asthma. So you can see even those with the mildest asthma, up to over 50%, were poorly controlled. So again, they probably shouldn't have been left in step 1. These are people who should be moving up. It's not surprising that you see a large incidence of patients with uncontrolled asthma in step 5, because that's the most severe asthma. But it doesn't seem to matter what degree of underlying severity you have or what therapies you're currently taking. There's still a good chunk of people who aren't actually technically well controlled based on these objective scores, anywhere from 44 to 84%. Next slide. The use of short-acting beta agonists is a key marker of asthma control, and good control according to the Canadian criteria is to use less than 4 inhalations per week of rescue therapy. When you consider that one canister of a rescue inhaler such as salbutamol or Ventolin contains approximately 200 inhalations, one of these inhalers should last, in theory, up to a year, but technically most patients do tend to take 2 puffs of their salbutamol when they do use a reliever. So depending on how you look at the math, either way, you shouldn't be refilling your SABA more than every 6 months if you're actually well controlled. And I tell my patients, this is my thermometer that tells me how well your asthma is actually doing. Next slide. Not surprisingly, in this same Inspire survey that I started off showing you, we do see obviously increasing use of the short-acting beta agonist early on when symptoms are starting to get worse. And this goes up to as much as a 4-fold increase of use when symptoms are at their worst. What's interesting is that you can see there is an increase in the use of the controller therapies such as the ICS and the combination therapies, but it doesn't mirror that same peak that you see in the updosing of SABA. So again, there's an issue with too much extra SABA use at times when symptoms are not well controlled. Next slide. So what's the big deal? Why do we care if people are using too much short-acting beta agonist? Well, the reality is that there's good epidemiologic studies that show that the more canisters of a salbutamol inhaler that you go through per month is clearly associated with asthma mortality. And you can see that on the graph on the left. So again, if you're using more than 6 inhalations per day on at least one day, not only is that predictive of an increased risk of death, but definitely an increased risk of exacerbation. And the more refills of your controller therapy, your inhaled corticosteroid, that are actually refilled per year, then that leads to a definite decreased risk of death from asthma. So again, you can see on the right-hand graph, those patients who filled 1 per month, so the 12 per year, they're at the very lowest risk of having further issues with their asthma. So we know it's really important to make sure that people are relying on their controllers more so than their short-acting relievers. Next slide. So again, some of the paradoxes in how we define asthma and even looking at our current guidelines for the management of asthma potentially contribute to this issue. So if you look at GINA step 1, again, short-acting beta agonist alone is recommended for the mildest asthmatic, despite the fact that we have just finished telling you that asthma is a disease of chronic inflammation with episodic worsening. So maybe we shouldn't have a category of just short-acting beta agonist used. Again, in step 1, the use of an as-needed short-acting beta agonist to control symptoms is accepted, but from step 2, we expect people to have a fixed dose approach with the goal of minimizing the use of the short-acting beta agonist. But we also know that while the inhaled corticosteroids treat the underlying inflammation, patients still perceive their short-acting beta agonist as the one that actually benefits them, because that's the one that makes them feel better and quickly. Safety messages on short-acting beta agonists and long-acting beta agonists are within guidelines can become confusing. Up until very recently, there was a black box warning from the FDA about a potential risk of death from long-acting beta agonists, and we know, of course, that that's only now recognized to occur if you use a long-acting beta agonist as monotherapy for asthma. But again, it does lead people to feel like their short-acting beta agonist might be safer because there was this black box warning about a risk of death attributed to the fixed-dose ICS-LABA combinations on the market up until very recently had that been removed. And as we have already discussed, there's a clear disconnect between a patient's understanding of their control and their actual symptoms. Next slide. So fortunately, we're starting to take a step in the right direction, and GINA guidelines have now actually taken a move towards considering inhaled corticosteroids from the initial dose. So again, it's not saying that you must use a controller at step 1, but consider it right away. And you can see from the way in which this graph is laid out is that the vast majority of patients with asthma should be able to be managed in that step 2 group of just low-dose ICS. So again, the concept being that we want to make sure that there's some degree of control or therapy available to patients so that we can minimize the inflammation that's actually causing the symptoms in the first place. Next slide. So why do we care about reducing exacerbations? Next slide. We know that having frequent exacerbations leads to clear decline in lung function. And in fact, you can see a significant difference between those patients who have frequent exacerbations and their annual change in their FEV1, or their ability to breathe out forcefully in 1 second. And it declines more rapidly every year if you're somebody who exacerbates more frequently as opposed to infrequently. Next slide. So what does lead to inadequate asthma control? Well, first and foremost, and that's one of the things that both the Canadian guidelines and the global guidelines strongly recommend, is to make sure, first and foremost, do you have the right diagnosis? Is there a confounding illness that we're not treating appropriately? Is the choice of inhaler for that particular patient not appropriate? Maybe there's nuances about the device that they just can't work it properly. They may be using poor technique in it, either on purpose or by accident. We certainly obviously know if you're still smoking or if you have unmanaged allergic rhinitis at the same time. And there's also just individual variations in treatment responses. For time to time, one patient will do much better on a different inhaled steroid than a different formulation. We know that there is a degree of undertreatment and there's a degree of unintentional or intentional non-adherence, whether sometimes patients don't fully recognize that the drug was actually prescribed to be used twice daily, and they're only using it once daily. That's unintentional non-adherence. Obviously, intentional non-adherence is there's issues around. Usually, these are patients who have trouble forwarding their medication, so they're trying to stretch it out and make it last longer, or other reasons. Next slide. So why does this paradox exist? Why are there issues with sometimes patients not taking asthma medications as prescribed? Asthma patients are no different than the rest of us. Lots of us don't want to take daily medications when we feel well. If you're not having asthma symptoms, it's hard to remember to take a medication for something when you feel quite well in between. And not unsurprisingly, a lot of people believe they know when they need their asthma medications because that's when they have their symptoms. A lot of people, as we've already mentioned, like to use their short-acting beta agonists because they work quickly and you get immediate relief. But I think, again, our job as physicians is to make sure that we're doing a really good job at educating patients about what are the risks of poor asthma control, what are the future risks, and really trying to underscore the importance of using your controller therapies whether you feel like you need it or not. Next slide. So that's when I warned you about this. We're going to go in for a blitz now about all the variable therapies to Canadians with asthma today. We'll talk about which ones actually target underlying inflammations, which are the ones that those with very severe asthma should be aware of, and what should be our new paradigm of asthma management in 2018. Next slide. So everyone's familiar with the short-acting beta agonists. Again, these have an onset of action between 5 to 15 minutes, and they last about 4 hours. There's 2 brand names on the market, Ventolin and Bricanyl. The salbutamol comes as either a meter dose inhaler or a discus. The important distinguishing factor here is if the patient is choosing to use a discus, you only need one inhalation because it's got double the dose. Next slide. Long-acting beta agonists, as I mentioned already, there is definitely a black box warning against monotherapy. There was a study that very clearly showed an increased risk of death with using this as the only way of treating your asthma. They're only indicated for children 12 years of age and up, and there's two in the Canadian market, salmeterol and formoterol. The important difference between these two agents really is the onset of action. So formoterol has an onset of action of 5 to 15 minutes, very similar to salbutamol, whereas salmeterol clearly takes up to an hour to have its full effect. And again, the salmeterol has an option between either an MDI or the discus, and the formoterol is through a turbohaler. So again, another dry powder inhaler or DPI. Next slide. We have lots of inhaled corticosteroids to choose from now, lots of options available. So as I mentioned, sometimes one patient will have will just not respond well to any given agent and will do better on another. I've listed them in order of which they were introduced to the Canadian market. Beclomethasone is actually a very old steroid, but the newer formulation, which is just a different type of inhalational aerosol through the brand name QVAR, was a way in which to get the medication into a CSC-free inhaler. So, but again, doses are available of 50 and 100 micrograms, but it's only available in a meter dose inhaler or a so-called puffer. Obviously, most people are very familiar with fluticasone propionate or the brand name Flovent. It does come as either a meter dose inhaler or a dry powder for inhalation discus. It's important to recognize, again, as an allergist, I'll always highlight some of these nuances, that the discus does contain lactose, which has not been shown that on occasion has milk protein in it. So this is not a good choice for patients who have milk allergy. There's a range of doses that are available. And again, the important thing to recognize if patients are using a meter dose inhaler is they do need to have a spacer device as well. Next, we have budesonide, or brand name Pulmicort. This is only available in a dry powder for inhalation through the turbohaler, and there are two different doses available. The cyclosinide, which is only available in a meter dose inhaler, or brand name Alvesco. One of the unique things about cyclosinide or Alvesco is it's a prodrug. So it only gets converted to an active steroid when it hits respiratory esterases. So it does have that advantage of only being active as quote-unquote a steroid when it's in the lungs. So that does potentially offer a safety advantage. And it can be given once daily as opposed to twice daily. All the previous medications listed above are all twice daily doses. Next to the market came mometasone with the brand name Asthmanex. Again, this is only available in a dry powder for inhalation twistaler. It is available in two different doses, and it's a once daily dose as well. So again, if you're thinking about concerns with people forgetting their second dose, these would be reasons to consider those options. Finally, added to the market was fluticasone furoate, again, a dry powder for inhalation through Ellipta. This device also does contain the lactose milk protein issue that we saw with the discus for Flovent. So again, just make sure that this isn't being given to patients with milk allergy, and it's also a once daily dosing. Next slide. Now we'll talk about the combination therapies. So again, where you've paired inhaled corticosteroids with a long-acting beta agonist. And again, we have numerous options available to choose from. The old standby, fluticasone paired with salmeterol or the brand name Advair, again available as a discus or an MDI. The one thing to note about the Advair MDI is it's one of the few that can be given to younger patients. There's an error on this slide. It's not actually 12 years. It should be 6 years of age and up, not 12 years in age and up. Next to the market came the dry powder formulation with budesonide paired with formoterol, going by the brand name Symbicort. So here we have the inhaled corticosteroid paired with long-acting beta agonist with the faster onset of action, as we heard about when we talked about the LABAs separately. A reminder that there are a range of doses available for each of these. A lot of people only remember sort of the 250, 500, but all of these formulations do have lower doses of inhaled corticosteroids, which become important to think about when you're looking at either younger people or also just dose steroid sparing in general, if possible. More recently to the market came mometasone, which is paired with formoterol, and again in a metered dose inhaler. So again, you need to have a spacer device when you use this, but again, a range of doses so that you do have some options with choosing different levels of steroid therapy. And we won't have time to get into differences about potency, but I will just mention that mometasone is a much more potent steroid than budesonide, so you would never want to make a direct switch between Symbicort 200 and Zenhale 200 because you've doubled the potency of the steroid exposure with that. So just a reminder, if somebody has decided they'd rather use a quote-unquote puffer as opposed to a turbuhaler, that the appropriate switch would actually be the 100 dose of the Zenhale formula. And then most recently, we have a fluticasone furoate paired with an ultra-LABA. So vilanterol actually has a 24-hour duration of action. It's only available in the Ellipta device that we saw the Arnuity inhaled corticosteroid was provided in. There's two doses, both 100 and 200 to choose from for the fluticasone furoate side of things, but this is a once daily drug, which does have some potential advantages, again, if people are concerned about adherence and remembering that second dose. Next slide. So how do people use their asthma inhalers? So we talked about the fact that there are those very, very mild patients that maybe just use PRN, just use their short-acting beta agonist as needed. Again, very quickly, though, people should be looking at stepping into using a fixed-dose, low-dose ICS or adding in a leukotriene receptor antagonist with using the short-acting beta agonist, again, as needed. There's an option to use a fixed-dose inhaled corticosteroid paired with a LABA, again, plus or minus a leukotriene receptor antagonist if appropriate, and use the short-acting beta agonist as needed, despite the fact you've got a long-acting beta agonist. And again, for all of those above, if you've got an acute exacerbation, most centers will recommend an asthma action plan where patients should double or perhaps quadruple their inhaled corticosteroid dose at the time of acute worsening, or sometimes it's necessary to introduce oral corticosteroids depending on how severe the exacerbation is. The other option is to take a different approach, which is a single inhaler maintenance and rescue therapy, or so-called SMART strategy, where you have a fixed dose of your ICS LABA and use that same ICS LABA on an as-needed basis for reliever, as opposed to using a PRN SABA. It's important to recognize that this is an only effective strategy if the LABA is formoterol due to onset of action differences between formoterol and salmeterol, and it's only Health Canada approved currently for Symbicort. But it is another option if patients only want to carry one inhaler, and sometimes this can be an effective strategy. Next slide. Again, this is just to sort of show the difference of onset of action between formoterol versus salmeterol, showing that you do see an immediate improvement within 5 minutes of someone's FEV1 with the formoterol beta agonist as opposed to salmeterol, which is much slower to achieve the same improvement in FEV1. Next slide. So just again, we want to round out all the options that are available. Leukotriene receptor antagonists, just of interest, these are also can be effective in seasonal allergic rhinitis in addition to asthma. Currently, we only have one available agent on Canada, which is Montelukast, which goes by the brand name Singulair, and there's 3 different doses, and it's based on your age, and it's once daily oral dosing. Next slide. So again, I think it's really important to make sure that we're taking a personalized approach to asthma management. We need to assess our patients' preferences and ability to use the different devices, and that can make your decision between, first of all, you're going to use a dry powder inhaler versus an MDI or a puffer. Some patients do have concerns about inhaled corticosteroids, so look at alternatives to steroids for maintenance, such as leukotriene receptor antagonists. If they're using an MDI, make sure an aero chamber is in use to minimize side effects of things like thrush and other complications that can happen if too much of the steroid hits the back of the throat. We can talk to the patient about how much they want to have immediate relief from their symptoms if they use their inhalers, and choose your ICS LABA accordingly. And again, choose the inhaled corticosteroids with the lowest bioavailability and therefore the lowest risk of adverse effects, but also that still produces the desired efficacy outcomes. Next slide. What about other options? So we mentioned, you saw early on, there's a range of severities. There's patients who are in that so-called GINA step 5. And are we stuck when patients don't get better despite ICS-LABA, despite using good inhaler technique, and we've confirmed the correct diagnosis? Are these patients stuck with being on chronic prednisone to control symptoms? And I would argue that in 2018, the answer is a robust no. Next slide. So again, just coming back to the overall message from the global initiatives, again, you're always reassessing before you adjust therapy, and you can see when you get up to those higher levels where patients are still exacerbating despite having high-dose ICS-LABA use with other agents, then we need to think about going to the next level of what's there in step 5. So next slide. Again, this is the Canadian guideline, and what I'm going to do now is we're going to look at the top of the triangle, which really focuses on what are our options now for severe asthmatics. Next slide. So again, now we've just blown up that top red triangle, and you can see we're always going to do the same thing for patients with severe asthma that we do for patients with mild and moderate asthma. We're always going to make sure that we're confirming the diagnosis, that we're giving them action plans, and we're educating them. They're all going to have access to short-acting beta agonists on demand, or maybe ICS-LABA if it's the formoterol component on demand. But now we're getting into things like adding in tiotropium. In some countries, maybe theophylline is appropriate. But now you're going to really get into figuring out the phenotype of these patients. So we're going to be measuring things like blood eosinophil counts. We're going to measure things like total IgE levels. We're going to suggest skin testing. Where available, we'll perform evaluations of how much eosinophil is actually in someone's sputum. If available, we can measure the fractional exhaled nitric oxide. Again, we're looking to try to better define who are these more severe asthmatics so that we can choose the right personalized strategy for them. So we'll get into more details of all these little options on the next slide. So again, first step for patients who are not responding to high-dose ICS-LABA would be to add in tiotropium. This is only Health Canada approved if you use the Spiriva Respimat device, which is a specific delivery device where all the studies showing the benefit of tiotropium in asthma were used. And it's 2 inhalations usually just once a day in the morning. Next slide. In terms of the biologic therapies, the one that we've had the most experience with in Canada now for 14 years is omalizumab. Some of you may know it by the brand name Xolair. This is a monoclonal antibody that binds the IgE molecule, and it is indicated for the treatment of moderate to severe allergic asthma, and has been well shown to decrease hospitalizations, emergency room visits, and decrease requirements for oral steroids. Again, this is typically given only under specialist supervision. It is an injection. There is a low but measurable risk of anaphylaxis. And currently, it's the only biologic for poorly controlled asthma with a pediatric indication. So it can actually be given to children as young as 6 if clinically warranted. Next slide. Recent, sort of more hot off the press and newly available are a number of different agents that target the eosinophil side of things. So mepolizumab is an antibody that binds IL-5, which is a cytokine that's important in eosinophil activation and survival, and it's indicated for the treatment of severe eosinophilic asthma. It's given as a subcutaneous injection by a fixed dosing regimen. Also recently approved at about the same time, but a little harder to get access to currently, is reslizumab, which is an anti-IL-5 agent as well that has a weight-based IV dosing, so there's an ability to adjust the dose that the patient receives. And very hot off the press, just approved about a month ago, is benralizumab, which is an anti-IL-5R agent. So it actually binds the receptor that IL-5 speaks through, and it's a much more targeted anti-eosinophil agent, if you will. There's more to come. Dupilumab is approved in Canada for the use of atopic dermatitis. It blocks both IL-4 and 13. Again, these cytokines are things that are important in allergic pathways. It's seeking approval for asthma in the States, and I'm sure we will see it in Canada as well down the line. And stay tuned. There's lots more things in development, so there'll be many, many options now for the severe asthmatic, and I think will render chronic prednisone obsolete. Next slide. So in summary, asthma is a chronic disease, and controlling inflammation is still the key to preventing symptoms and exacerbations. Avoidance of triggers with ongoing education are both essential components of asthma management, not just prescribing an inhaler. making sure that we review device technique and adherence whenever possible, recognizing and trying to communicate to our patients that uncontrolled asthma and severe exacerbations will accelerate the decline in lung function. And so adherence and a clear understanding of the disease is the key to good control. I think it's important to recognize that many new therapies exist for severe asthma, and I'm hoping that chronic prednisone will be a thing of the past by the time I'm done my career. And I thank you very much for your attention, and I can tell there's lots of questions coming because I see them popping up on my screen as we've got along.
Sorry about the delay. I was on mute. Thank you so much, Dr. Ellis. That was an amazing presentation. I learned so much. We do have a number of questions. Just one moment. So we have a question from Allison White about which category Advair falls under.
What do you mean by category?
From what I understand, it would be whether it's a LABA, SABA, combination, etc.
Yeah, so Advair is an ICS LABA, so it's the combination of fluticasone propionate with salmeterol, so it's an ICS LABA. Yes, and that's a good point. Pulmicort is available as a nebule that we can use in nasal rinses. They can actually be put in an actual nebulizer as well for the pediatric indication if children have severe asthma in young ages and can't yet use inhalers properly. And interestingly, there's a unique condition called eosinophilic esophagitis, and we use Pulmicort respules to swallow to treat that condition. So thank you for that point.
Okay. So we have another question here. I work at a family medicine walk-in clinic, and I frequently encounter patients who are told they have asthma or believe they do. However, they either have no spirometric challenge test verified diagnosis in their medical records, or are unaware if such formal testing was ever carried out. What are your thoughts on the importance, impact, and implications of the above in the proper management of asthma? What are your thoughts on how we can or if we should encourage formalized diagnostic testing and documentation in patient charts, and if this may have real-world impact on improving outcomes for patients, either by reducing of diagnoses or by allowing for better comparison to baseline PFT measures for patients to track their disease course and adjust management plans accordingly.
Okay, so thank you, Dr. Carr, for that observation, and I think it's a really important point. It actually is essential to try to confirm the diagnosis of asthma objectively, whether it be through reversibility on spirometry testing, variability in peak flow if patients don't have easy access to a PFT lab. You can give them a peak flow meter, and they can show greater than 20% change over the day as an objective measure of hyperresponsiveness. And obviously, methylcholine challenge can be used when neither of those give you the confirmatory answer you're looking for. The reason why this is important is, in fact, this is from a Canadian study by Sean Aaron out of Ottawa, who did a very extensive evaluation across Canada through a random digit telephone dialing approach to find patients who said they had asthma, and then he actually brought them all in to centers across the country that could do this testing, and found that in up to 30% of those people who had either believed they had asthma, or I think they included patients who had physician-diagnosed asthma. Actually, 30% of them did not have asthma at all, and I can't get into the full details of all the other diseases they had instead, but again, it just does emphasize the importance of making sure that you've got the disease right, because if we don't have the disease right, then all of these therapies that I just went through with you, none of them are going to work properly. So thank you for that point.
Thank you. So another question asks, does the 4 times a week use of SABA include exercise-induced pre-medication?
A good question. No, we don't typically count that. Whether or not we should is up for a bit of a debate, though, because some people think that exercise-induced bronchospasm probably should be managed just like asthma. But right now, as of the current guidelines, you're allowed to not count those. But it is a bit of a controversial area depending on who you talk to.
And another question, why is it harder to access Reslizumab versus Mepolizumab?
It mainly has to do with just how the product was launched. Reslizumab is distributed by a company called Teva, which is mainly a generic company, and they had very little experience in things like patient support programs and sort of actually delivering brand name products to the market in general, let alone a complex biologic that has to be given through the intravenous route. So they decided to do a soft launch in Hamilton to make sure that they had the ability to get their patient support program working properly. It's soon going to be much more easy to access across the rest of the country. But that's why I had that comment and why a lot of people aren't familiar with Reslizumab, because right now it's really only being given in McMaster University in Hamilton. Whereas Mepolizumab has supported by a very large pharmaceutical company that has good access to sales reps and science liaisons and patient support program that has made it launch very successful.
Do all DPI inhalers contain lactose monohydrate carriers?
I believe it's just the ones that are either the discus or the Ellipta device. Certainly, it's the discus device that's got the case reports of having contamination with milk protein.
Thank you. And we have a question. Do you see patients, and where is your clinic?
Oh, thanks. Yes, I do see patients. I run clinics out of Hotel Dieu Hospital here in Kingston, and I have 2 standing half-day clinics a week. Again, I mainly do research, but I add on clinics from time to time when cancellations in the schedule allow. But yes, I see patients.
And how important is reducing indoor air pollution?
So this is really important. So again, I think a lot of patients don't recognize what harms they're doing to themselves with air fresheners and Febreze and Lysol sprays. We actually published a study earlier this year showing that exposure to indoor scented products was clearly associated as an independent risk factor for respiratory symptoms in children who are 1 to 2 years of age. And that was independent of whether or not parents were smoking, independent of all the other things that are known to increase your risk of respiratory symptoms. So I think we need to spend more time talking about things like that and making sure people aren't using scented candles and air fresheners if there's an asthmatic in the house.
Thank you for that. We have another question. From time to time, a patient presents with what can be considered allergic asthma with little or no response to steroids. They sometimes claim they're allergic to steroids. Is there such a thing, or is it that they respond to one of the biologics, and what do we do with such a patient?
So the patients who are non-responders to steroids, again, assuming that they're actually being adherent to steroids and they're actually using the inhalers appropriately, typically those are those patients where if we have access to things like induced sputum, we can find out that they actually have neutrophilic asthma, and they are very steroid resistant. We don't have good directed therapies for the true neutrophilic asthmatic at this point. So again, I think it's worth, if people really aren't responding to moderate to high doses of inhaled corticosteroids with or without other combination therapies, those patients should be referred on to specialist assessment. As to the question of they're allergic to steroids, I mean, we do see steroid allergy from time to time, but it does not manifest as my asthma doesn't respond to it. It manifests as more typical symptoms of allergy, such as hives, etc. But I think the key is if they're really not getting better, they need to get sent up the chain to areas where more specialized testing can be done.
Okay, and how do you select which biologic to use? And how do you choose between reslizumab, MIPO, and Benra?
So again, that's why it really comes down to that importance of phenotyping the patient. So anyone where you're contemplating going the route of using a biologic therapy, you want to make sure you're getting a CBC and differential, so you have an eosinophil count. You're going to get a total IgE level. You're going to arrange for skin testing, or if you're not in an area where you have easy access to an allergist, it might be worth considering measuring serum-specific IgE levels to try to find out what their allergic background is. And you start with that, and you also look at the degree of the severity of the asthma. So again, if you think back to the blown-up triangle, omalizumab, again, is indicated for moderate to severe asthma. So for those patients where you think they deserve a biologic, but maybe they aren't the ones who are getting 2 or 3 courses of prednisone per year, they're not on oral corticosteroids all the time, that might be a good starting point. But those patients who have high peripheral eosinophil counts, that they're needing more steroids or they're steroid dependent, that's when you really probably are going to be better off with the anti-IL-5 or anti-IL-5R agents, because they appear to be a bit more potent in clinical trials. But again, there are certain criteria based on you have to have a certain level of eosinophils in the blood and a certain degree of severity. So again, the companies that pay for people's insurance companies will only pay for these expensive products if they meet that threshold of severity. As for choosing between the 3 anti-IL-5s, right now it's hard for me to access reslizumab, so mepolizumab has been my go-to anti-IL-5 up until recently, and again, benralizumab product just came on the shelves like a week ago. So how that will play out over time will be based on our clinical experience with all 4 of them and how things go.
Great. Do we consider essential oils as bad products and triggers?
So again, it depends on the scents that are associated with the essential oils. I mean, I would any patient with asthma or any chronic respiratory condition for that matter can respond poorly to any volatile organic compound. So I would usually recommend if you're talking about an essential oil that's being used to sort of fragrance your house, that would be something I would not recommend for asthmatics.
Okay. And do you collect data of people with unconfirmed asthma but experience asthmatic episodes?
Do I collect data? I mean, I certainly have patients where they present with what seems to be asthma, and if it hasn't been confirmed, I make sure I do those confirmatory tests. In my studies, though, you usually can't get into a study of asthma if you don't have those confirmatory tests.
Okay, great. Do you think it helps an asthmatic to replace cabin air filter regularly in the vehicle?
It's a good question. There's not a lot of data on that. I'm not aware of particular studies that have done that to try to see if it actually has an impact. I think it's just sort of good practice, just like you should frequently change out the air filters in your home just to make sure that you're not circulating dust and other particulate matter. I don't think it's not harmful. I think it's probably a good practice, but I can't tell you that I'm aware of a study that proves that it's essential to do.
Do we have any other last-minute questions? Great. I think we've gotten to all the questions that our attendees have asked. Thank you so much, Dr. Ellis. This was very, very informative, and we really appreciate taking your time to speak to us. And just a reminder to everybody, this was the first of our speaker series webinars. We do have another one coming up in celebration of World Asthma Day on May 1st, and we strongly encourage you to register. And registrations are open. I will paste the link on the chat box, and we really encourage everyone to register and join us for that one. And thank you again. This webinar was recorded and will be made available on our website as well as our YouTube channel. And thank you to AstraZeneca, who partly sponsors our speaker series webinars. and wishing you all a great rest of the week. Thank you again, Dr. Ellis.
You're welcome. Thanks for tuning in.
Thank you.